The Rome trial was a phase 2 trial with the aim to demonstrate if the diagnostic approach could be superior to standard of care. And then the Rome trial was a randomized multi-basket phase 2 multicentric trial in which patients affected by several kinds of tumor were screened with foundation 1 bone tissue and liquid biopsy. Once molecular alteration that could be targeted with a drug available in the Rome trial was identified, the clinical case was discussed in the molecular tumor board, and molecular tumor board decided whether to enroll patient or consider patient as a screening failure. All patients enrolled were randomized 1-to-1 to receive standard of care or targeted therapy. The primary endpoint of the Rome trial was objective response rate, and the Rome trial met its primary endpoint. The objective response rate was 17.5% in targeted therapy versus 9.5% in the standard of care. The targeted therapy also demonstrated an improvement in progression-free survival. Indeed, the median progression-free survival was 2.8 months in the standard of care versus 3.7 months in the targeted therapy, and was impressive also the PFS rate at 1 year that was 22% in targeted therapy versus 7.7% in standard of care. At ESMO Breast 2025, we have presented the cohort of patients affected by breast cancer. Among 1,794 patients screened, 169 patients were affected by breast cancer, so 9.5% of the population. The most frequent genomic alteration in this cohort of patients were TP53 in 57% of patients, followed by PIK3CA in 41% of patients, ECR1 in 24% of patients, FGF19 in 24% of patients. In 12% of patients, we had also a concomitant mutation of PIK3CA and SR1. The median tumor mutational burden in this cohort of patients was 4 mutations per megabase, and 29 patients, so the 17% of patients, had high tumor mutational burden. Among these patients, this cohort of breast cancer patients screened, 40 patients were randomized to standard of care or targeted therapy, and in the overall population, objective response rate, or progression-free survival, and overall survival was not superior in targeted therapy compared with standard of care. However, if we consider patients with high tumor mutational burden, even though the sample size is very small, only 11 patients, in this group of patients, the results are really interesting. Indeed, the objective response, all these patients were treated with ipilimumab plus nivolumab as a targeted therapy, and the objective response rate was 40% versus 17% in the standard of care. The disease control rate was 60% versus 17% in targeted therapy compared with standard of care. The median progression-free survival was 16% versus 1.9 months in the targeted therapy, and the PFS rate at 1 year was 70% versus 0 in the standard of care. The overall survival was not reached in the patient treated with EB plus Nivo compared to 1.9 months in standard of care, and the 1 year overall survival rate was 80% versus 0. We have also classified patients according to the ESCA scale, and patients classified at ESCA scale 1 or 2, 14 patients, had 29% of objective response rate compared to 0 for patients classified as ESCA more than 3. The median PFS was 7.6 months in ESCA scale 1 or 2 versus 3 months in ESCA scale more than 3. The median overall survival was 24 months in ESCA scale 1 or 2 versus 7 months in ESCA scale 3. So in conclusion, these findings from the Rome trial underscore the clinical relevance of molecular profiling also in the breast cancer cohort of patients. While no significant differences were observed in overall population, the improved outcome in patients with high tumor mutational burden suggests that tumor mutational burden may serve as promising predictive biomarkers for targeted therapy. Notably, patients with high tumor mutational burden who received targeted therapy showed significantly longer overall survival and progression-free survival compared with patients treated with standard of care, reinforcing the importance of incorporating TMB in the routine clinical practice. This analysis, in conclusion, support a biomarker-driven approach also in breast cancer patients, and larger prospective studies are needed to confirm these results.